Hey, hi, greetings to all. Thank you for joining the session. Today we have our SME, our expert, Prof. Andy Barraclough. I invite you, I welcome you, sir. Thank you for joining. Thank you for your time and support. We can start with the session now.
Okay, if I take it all the way through then. Okay, greetings and welcome to everyone. I see we have not so many with us today, but never mind. We'll have an exciting session anyway. Our usual housekeeping announcements. Please mute your microphone and turn off your video until we get to the question and answer sessions. You can ask a question at any time by typing in the chat box. During the Q&A session, please do not unmute until you're invited to do so. As always, the webinar recordings will be available for the participants and the slide deck will be shared with you. The objective of these expert session webinars is to give you a chance to ask any questions, and hopefully the expert will try to answer them. In the course of this, the speaker will summarize the module and then invite questions. Our agenda for today is around the 20-minute session of me talking, summarizing part of the module, a Q&A session for 10 minutes, a second 20-minute session of presentation, and then a longer 15-minute Q&A session. Please type your questions in the chat box at any time that we're undertaking the presentations. I think by now you're all familiar with me. If you've got to this module on the course, you'll have heard my voice a great deal already, so you already know who I am. So on this module on storage and distribution, our first task is to dispel any myths that we have around that. And unfortunately, there's a lot of misunderstanding about storage and distribution. We ask the basic question, why are we undertaking storage and distribution? Many people will say, well, it's obvious. It's part of the supply chain. We've got to have it. And that's largely true. But understand, within public health, storage and distribution has no value on its own, only as part of the supply chain. We don't undertake storage and distribution because there's some intrinsic value in storage. We don't want to be doing storage. We do it because we must. We must do it in order to get a flow of commodities. And again, warehouse managers and people who really should know better often misunderstand. They talk about storage. Storage is not what we want. What we want is a flow of commodities, always like a river, a flow. We undertake storage in order to ensure a regular flow, just like building a dam on a river. We build the dam not to stop and store water, but to give us a regular flow of water during the dry season. If we're not certain that we're linked to our public health goals, then nothing we do can make any sense. So our first message is debunk the myths. Storage and distribution is part of public health. We are doing it because it delivers public health. It's an essential tool, an essential mechanism to deliver public health by providing a flow of commodities. Always a flow is what we want. And the overarching goal is to achieve public health targets. I can only do that if I have diagnostics and medicines and all the commodities available at point of use. So it's an essential part of public health. But we have to be clearly connected to public health. And too often we forget that connection. We forget that interlinkage. And then things don't go well for us. So too often we say, we need a new warehouse because of the volume of stock. That's the wrong approach. The approach should be, if we are to achieve the public health goals, we need a new warehouse. That's quite a different message. Our message is achieving public health goals. We need the supply chain, we need storage to be able to do that, but it's a tool to achieve public health goals. Well, what are our public health targets? They're usually in the National Health Strategic Plan, and that's usually a 5-year plan. How many have ever looked at your strategic plan? All our key performance indicators must be based around achieving public health targets and not on administrative convenience. If the public health target is reducing maternal mortality by 20%, how does that impact us? Well, to do that, I would need to supply oxytocin injection. That's a cold chain product. So I'm going to need a functional cold chain. I'm going to need refrigerators, refrigerated trucks, cold transport boxes, all the material that goes with the cold chain. But let's understand, I'm not doing it because I want to store oxytocin. I'm doing that to meet the stated public health target of reducing maternal mortality. So if we keep that focus of achieving public health targets, then what we do makes sense. There's a reason and there's a logic behind it. But just a minute, I'm a PSM officer. How can I know about all these health goals and what they mean? There's hundreds of health goals. I can't expect it to know what it means for the warehouse and distribution. And frankly, no, as an individual, you don't need to know. But you do have to be aware of the source and the overall hierarchy and structure of what we're doing, because that's the linkage. And if we're not fully linked, we're not performing well. So the National Health Strategy will set the policy and the health targets. The National Drug and Therapeutic Committee will decide which medicines are needed. That's the selection process to meet those targets. The standard treatment guidelines will decide what dosages are required to meet those targets. And that decision has a big impact on us. If they go for 5 days of antibiotic treatment, that's a very different quantity from going for 7 days. I need more storage space, more transport. So everything they decide impacts what I do in storage and distribution. The forecasting team will estimate the quantities required. And again, that will impact my storage and distribution. The procurement team will decide how and where to buy the medicines. Now you get to decide how to get them to the patients, where to store them, where to distribute them. The point I'm making here is the whole process is interlinked and interconnected. If we don't recognize those interconnections, then storage and distribution doesn't work. Always we must recognize the linkages and how they impact what we're doing. So our key points around this are: understand why we are undertaking storage and distribution, because some countries don't. We store to get a regular flow. Some countries have a lot of manufacturers, like Indonesia, and they deliver directly from the manufacturer distributor to the sites. The same in Thailand. They have lots of manufacturers. They don't have a central store. They deliver directly from the manufacturer to the sites. We store in most of our countries because we have to get a regular flow. So understand the flow process and why we're doing storage and distribution. It's all about flow. How can I ensure a regular, reliable flow of commodities? Understand our goals and priorities, and where they come from, the health priorities. And understand the impact of our activities and what happens when we fail. Increased morbidity and mortality. People die. More importantly, be prepared to explain these key points to policymakers and advocate for the resources and funding we need to do the job. because most people in administration don't recognize this. They don't know this is what we're doing. We have to try and explain it to them regularly. One of the fundamental problems we've got on storage and distribution, as we explained in Module 5 on inventory management, is many public sector supply systems have never specified their service levels. What's the performance level they're trying to achieve? How much are we going to be able to supply from stock? Again, many of the administrators in the Ministry of Finance, who we have to try and get money from, don't understand any of this. They'll say, you must have 100% performance. There's no place in the world that's got 100% performance. We have to try and bring some reality to this, some understanding to these kind of statements. Once we've got a clearly defined service level, we can plan how to operate and the resources and funding that we need. So the service level realities. It's generally believed that the UNICEF supply warehouse in Copenhagen in Denmark is the largest essential medicine warehouse in the world. It's 20,000 square meters and 5 stories high. They do not have a 100% service level. They cannot supply everything from stock. There is no transport fleet in the world, not DHL, not FedEx, not any of the big courier companies that can achieve a 100% service level of immediate delivery. There's no public health service system in the world which can ensure 100% supply chain service level. If we look at examples from high-income countries like North America and Europe, they report stockouts as well. So let's understand the reality. 100% is a dream. It's not achieved. So all the statements by ministers and other people who ought to know better, we have to try and explain that's not realistic. We need to have realistic service level targets. The service level will dictate how much stock you keep and how large the transport fleet will be. So I must have clear service levels. The key point around this is the relationship between stock and safety level is not linear. As I increase the service level, it's exponential. I have to have a whole lot more stock for increased service levels. The next few slides, the numbers will help to explain some of that. So the higher the service level, the greater the stock holding is needed. So for an 85% service level, I would need my normal safety stock. And you might just remember from Module 3, the normal safety stock is calculated on the lead time. So if my lead time is 6 months, I would hold 6 months buffer stock. And that's the Z score on the right-hand table there. And that will give me an 85% service level. What that means is that 85% of the time, I will have it in stock and be able to supply it to the clinic. If I increase now to a 95% service level, I need 1.6 times the buffer stock, quite a lot more. And if I go to 98% service level, I need 2 times the buffer stock. So if my buffer stock is 6 months, because my lead time is 6 months, to get a 98% service level, I have to have 2 times. Means I've got to keep 12 months buffer stock. Most of our warehouses, that's impossible. I don't have the space. I can't possibly achieve that. Even if I have the space, I don't have the funding to achieve that. And to get to 99.9, I need 3 times the buffer stock. That means I would be at 18 months buffer stock in the warehouse. So setting 100% service levels is nonsense. It's utter utopia. It's not something we can ever achieve. And we have to try and explain that to administrators and ministers who really should know better when they keep saying we want 100% service level. That's not achievable. So what is a reasonable service level for what we're doing? Typically, we try for around 85%, and then for critical items, we try for 95%. So 85% means my normal buffer stock calculated on the lead time. For very important critical items, I might go to 95% and look at 1.6 times the buffer stock. So recognize the impact of these service levels on the amount of stock we've got to keep. Trying to demand 100% service level is just impossible. Be prepared to explain about these service levels and what they mean and how often we can be expected to have items in stock and how often they're going to be out of stock. A further point is, in the public sector, even if I have the warehouse space and the distribution capacity, I don't have the funding. Most of the time, I don't have enough money to buy all the medicines I want anyway. So if I'm going to try and keep 3 times buffer stock, it's going to be impossible. I will never have the funding to be able to do that. So it's a combination of both physical space and financial economical reality that we need to bring to the discussion. Now, the point about this is I don't have to have the same service level for every item. And I don't have to have the same service level for every level, supply level in the system. Central warehouse could have a different level to district warehouse, could have a different level to the hospital and clinic. First is around the items. Some items are vital, they're life-saving. So it would make sense to have a higher service level for them. Insulin. If people don't have it, they will die. I probably should set insulin, because it's a vital item under the Venn analysis, as 95% service level. I'm going to keep that in stock, and that means I've got to hold a lot of buffer stock. Paracetamol, no one is going to die if I don't have paracetamol. That's only an N, non-essential item, so I can set the service level at 85%. And again, at the different levels, at the central warehouse, it actually doesn't matter if I'm out of stock because I'm not dispensing to patients. At the clinic, it really matters if I'm out of stock because I'm dispensing to patients. So I need bigger stocks at the clinic than I do at the central level. I need a bigger service level at the clinic than I do at the service level. So different levels, operational levels, can have different service levels. Well, what does this mean? I could get 99% service level at the centre quite easily, and probably 95% at the province. But if there was any delay in delivery, the patients wouldn't get their medicines. So that's not a good idea to have a high service level at the central level, because I'm not dispensing to patients at the central level. Where I need the high service level is at the clinic, because they're dispensing to patients. So where I set the service levels, where I keep the buffer stock is important, because that will affect the service level operations throughout. So what are my storage system goals? Adequate infrastructure. Well, that's a very vague word, the adequate, isn't it? What does adequate mean? The adequate means responding to the service level. If I've got a 95% service level, I need a lot of space for the buffer stock. If I've got an 85%, I just need normal space for my normal buffer stock. Storage facilities are well located, and often they're not. We've got a store because there was always a store there. Did we plan its location? Has the city grown up around it? Often we're hemmed in by traffic. It's not in the best locations. Correct environment, we'll talk more about in session 2 of this webinar. And the storage facilities are manned by trained and skilled human resources. Adequate, comprehensive tools and stock management tools. So all of that is in good storage practice, which we'll talk more about soon. The point around this is the adequate is connected to the service level. That's how important the service level is in understanding the resources that we need to undertake storage and distribution. So in the distribution system, again, we've got this word adequate transport. And that, again, keys off the service level. If my service level is 95%, I'm going to need more transport, more regular transport to ensure that everywhere is going to have stock all the time, so I can undertake regularly deliveries throughout the country. Ensure minimal loss of supply by damage and theft, lots of new techniques for that. Again, human resources, cost-effective manner, reducing operational costs, lots of software available to assist transport planning. Well, that's all great, but what does it actually mean, Prof? I mean, you've talked a lot about this. What does it mean? It means that what we're doing is interlinked. Recognize this interlinkage because it drives what we are doing. The health policy decides what we store through the Drug and Therapeutic Committee. They select the items. The standard treatment guidelines decide how much we store because they set the dosage and treatment regimens. Whether it's 5 days, 2 tablets, or 7 days, 8 tablets a day will affect how much I need to store. The service level affects how much I store for the buffer stock. So that's a big impact on the service level. And it affects where I store it. The higher the service level, the more buffer stock I have to put at dispensed patient locations. It also affects the size of the distribution team, how much transport, how much trucks I need. Recognize this interconnection. Too often, we're trying to run the warehouse or the transport fleet in isolation without any reference to anything else. And that's not a recipe for success. Recognize where the hierarchy is, what we're doing, where that comes from. Okay, it's time for our first Q&A session. I see we're just about on time. So, have we got anything in the chat box, Priya? Do we have anything there? If you'd like to ask a question, please raise your hand and we'll come to you. I've talked too much, there's no questions, okay. If you have a question, please raise your hand. Little icon on the bottom of the screen to raise your hand or type a question in the chat box. No hands, no questions. Must be too easy for you. Okay, chat box, what have we got? How do we come up with a distribution strategy? Okay, we start by setting the service level. What is our service level? Our service level is 85%. Okay. Typically, I would achieve that by having 1 month stock at dispensed to user locations, the clinics and the hospitals. And that means I would need to have a 1 month delivery. Does that make sense? For some locations, yes, a delivery every month is possible. For others, they're too remote. I would need to come up with 3 months. And then I would have to look, how can I achieve that with my service level? My service level is 95%. I'm going to have to keep 1.6 times buffer stock. So if I supply every 3 months, my lead time is 3 months. I've now got to keep 1.6 times 3 months. So around 5 months buffer stock at the clinic, and I would distribute quarterly. So the distribution is linked to the service level. What is the service level? Then I can come up with the distribution. For urban areas, monthly delivery is usually better. For remote rural areas, quarter delivery sometimes has to suffice. And for some very remote areas, they have to do it every 6 months, because for a large part of the year, it's flooded or there is snow and they can't get through to deliver. So geographic, climatic conditions also dictate. But the start of a distribution strategy is what is the service level at dispense to user site. When I've got that, I can then work out how much stock I've got to keep, and then I can look at how frequently I make deliveries. Okay. Any other questions? You can raise your hand and you can just speak if that's easier.
Please raise your hands if you have any questions related to the topic, or you can simply drop your message in the chat box. We'll take it from there. We are waiting for you.
We'll take any questions on Module 6, storage and distribution. Doesn't have to be on what I presented. Okay, then let me ask you a question. How many of you had understood the impact of service level before on storage? Please type in the chat box if yes or no. Okay, from the back, Anki, Derek, yes, okay, well done, good. Anyone else? Have you understood the impact of service level on storage before, yes or no? Faith, okay, yes, good, excellent. Looks like I'm preaching to the converted. Everyone already knows about the impact of service level. More, yes, okay. Tapshak Keshia, thank you. Yes, okay. Daryl Mackerman, yes, looks like everyone understood service levels before. Okay. You all got that from Module 5 and your own work. Good. Okay, then, Priya, I suggest I go on to the second presentation and we just have a slightly longer Q&A session at the end.
Yes, sir.
Okay. Okay, so in storage and distribution, what are we trying to achieve? And the answer is that we're trying to achieve WHO Good Storage Practice, GSP, and WHO Good Distribution Practice, GDP. And I'm sure by now you all know about these G. When we say good, we don't mean general, we mean a specific set of regulations and guidelines under the good series. We have good laboratory practice. We have good manufacturing practice of pharmaceuticals, and this is around good storage practice and good distribution practice. That's what we're trying to do. And I'm sure you've already referenced the WHO documents on good storage and distribution practice and looked at everything that's contained in there. They're very detailed. There's a lot of information in there. So a lot of things we need to be doing to achieve good storage and distribution. In the graphic on the right-hand side, you can see a quick summary of all the different ones that we should be doing and should be undertaking as part of good storage and distribution practice, GSP, GDP. Now, the key message around GSP and GDP is they're cost effective. We just take a moment, even a very small central medical stores like Botswana, the population of Botswana is quite small, will contain at least $2 million worth of medicine. Wastage rates of 7% are not unusual. If you implemented GSP, you would get the wastage rate quite easily down to less than 3%. That will save you $100,000 per year by implementing GSP. How many brushes and cleaning cloths to keep the store clean can you buy for $100,000 a year? How many automatic temperature recorders can you buy for $100,000? How many extra staff can you employ? How much more racking can you buy? How much more medicine can you buy for $100,000? The message here, proven beyond all doubt, is that GSP costs money to implement, but produces major long-term cost savings. GSP is very cost effective. That's our key message that we have to try and communicate to all the administrators and all the people that we have to deal with to obtain resources and funding. Well, if that's the case, why is it so hard to have GSP, GDP, and why don't we have it already? Because relatively few countries, public sector, are GSP, GDP certified. A few are, but not many. Firstly, there's a lack of recognition. Private sector recognize GSP, GDP quite well, and many pharmaceutical distributors have it. But within the public sector, it's not well recognized. And many don't really know why it's important. There's a lack of resources to undertake it. It costs money to implement GSP and GDP. It's cost effective, it saves money, but I need to spend money to do it. Crudely, just very crudely, because it varies a lot according to your geography and the mix of medicines you use. GSP, implementing good storage practice, being certified to GSP levels, will cost about 5% of your annual turnover. That's the annual drug tender. Think how much you put out on the drug tender each year. You're going to need 5% of that cost to undertake good storage practice. GDP is much more variable depending on the geography of the country, what roads, what railway you have available, and can vary between 3.5 and 15%. In some countries made up of tiny little islands, it's very expensive to deliver everything by boat. In some areas, deliver by light aircraft, again, very expensive. Other areas where there's good roads, it's relatively cheap at around 3.5% to undertake distribution. Problem we have is that many of our countries are trying to do storage and distribution for less than 1% of the annual turnover. It can never work. We have to be able to advocate for adequate levels of funding. It's that word again that we mentioned before, adequate. What do we mean by adequate? Observing good storage and distribution practice. I need adequate levels of funding. We look at some of the cost estimates, and these are real examples. So one country is charging the Global Fund 7% to distribute supplies funded by the Global Fund. And here is a problem. Why haven't you got resources? Well, often because you're not asking for them. Less than 5% of countries include storage and distribution costs in their Global Fund grant applications. They're not asking for any money. This country is, and it's having a debate about whether it should charge them 7% or 5%. In fact, for the particular supplies, they're high value supplies. So ACTs for malaria, ARVs for HIV, they're quite high cost medicines. So 5% is probably enough. The main point is they're asking for the money to do it. Not just the commodities, they're asking for the money. In case study 2, you can see storage costs of 13% and transport costs of 45% because they're delivering the last mile. They're actually delivering to individual clinics, and that's very expensive. But they're not unusual costs. That's the level of funding that we need to do the job. And you'll find those in the Guide to Public Health Spending Cost Estimates on the USAID publication shown on the right of the screen. So they're real examples, real costings. That's how much money is required. So why don't the governments pay us the money? Well, often there's not even a budget line for logistics. You see the report from Yemen, they had no budget at all for logistics. It just gets lumped in with the medicine costs somehow. There's not much recognition of the essential function of logistics. There's no one to advocate for logistics, so the message becomes drowned out. There's no recognition of the cost of logistics. Here's an example. This country is hiring a warehouse to store expired stock, $500,000 a year. It's nonsense. How can you be spending that much money? Because you're not looking at the costs. There's no recognition of the cost of logistics. We have to try and advocate and bring that message forward. And many countries are not willing to pay for storage and distribution of donated goods. They believe the donor should pay. And yes, the donor should pay. Donor will only pay if you ask them to pay. They're not going to volunteer to pay. So we have to try and get our resource requirements into the grant applications. Medicines with a fee for storage and distribution. This particular one was 9%. So the country had got a policy to ask for 9% of the cost of the donated drugs, but rarely implemented it. We have to bring that forward. We have to advocate for that implementation so that we get enough money to undertake storage and distribution. Is there any hope of us ever getting adequate funding? Is it ever going to happen? Well, there's some encouraging signs. We've seen countries issuing strategic plans for supply chain. That's a good start because that sets out where the money is coming from. If you've been following the supply chain in Daba in Zambia, then you'll have heard Zambia's minister saying, yes, we need to study this. We need to look at how this is going. So even at high level now, there's recognition. But also COVID has highlighted many of the problems of supply chain. So there's now a much greater understanding about the importance of the supply chain because of all the disruptions from COVID and how we have to fund it in the future. So there's more hope now than there's been for many years that we can get an adequate level of funding for storage and distribution. So what can we do? Well, in the longer term, we've got to advocate for good storage practice and good distribution practice, and advocate for the resources and the funding that we need. Include storage and distribution costs in all donor grant applications. We're asking for medicines or medical products. There should be at least 5% for storage and distribution included. Not just the medicines, money for storage and distribution. That's in the longer term. Advocating takes time. In the shorter term, yeah, sorry, can we mute, please? In the shorter term, we have to focus. We probably can't do everything yet on good storage and distribution. So identify the critical items in your country and then choose one area to improve and build on that. After that area, go to the next area and build on that as we move forward with good storage and distribution practice. One area we might focus on is temperature control. So many of our warehouses don't have aircon, or they only have a small aircon area. Not all the warehouse is air-conned, and it gets very hot. Point around that is to recognize that not all products are that temperature sensitive, and not all areas in the warehouse are the same temperature. So there's actually something we can do towards good storage practice, even with very limited resources. One of the problems is there's a lot of misunderstanding around temperature. People think store below 25, if it goes above 25, it's dead, can't use it. That's not the case for most items. It's misunderstood, and it's grossly misunderstood. In order to bring some sense to this, we have to look at quite a complex concept, which is called the mean kinetic temperature, MKT. We'll explain that in some details. It's specific for pharmaceuticals, although it's increasingly being used in the food industry as well. The first point to know is that the pharmaceutical damage temperature curve is not linear. So how much damage I do, of course, depends on the temperature. The higher the temperature, the more the product will be damaged. But it's not linear. It's an exponential curve. So if I increase by 5 degrees, from 25 degrees to 30 degrees, yeah, it increases the damage, but not very much. But going another 5 degrees, from 30 to 35, increases the damage a lot more, because it's exponential curve. When I go from 35 to 40, that's a really big increase in the amount of damage to the product. So the first message is the temperature damage curve is not linear. So the higher temperatures do a lot more damage, not just in proportion, a lot more because of the exponential nature. But around that, let's recognize that not all drugs are all that temperature sensitive. This is a study from the British Medical Journal, where they put all these items on boats and shipped them around the world with temperature monitors. And some went from -3 to 42 degrees. And they did that, and in fact, most items were not damaged. Ampicillin, benzyl penicillin, phenoxypenicillin, tetracycline were not damaged. Only ergotamine was damaged. So not every item is all that temperature sensitive. And here you can see a list of items and the damage. And on the left, we look at aspirin. Aspirin was kept at 40 degrees for 4 weeks. There wasn't a lot of damage. It wasn't a problem. It didn't become a problem till it went to 60 degrees. I hope none of our warehouses are at 60 degrees. If they are, you should be baking bread in them. Okay? But at 40 degrees, the aspirin still wasn't damaged. So not every item is all that critical. It's not good to store them at elevated temperatures, but it's not absolutely massively damaging for all of them. So how do we equate that to my real life situation? Because in my warehouse, the temperature is not 40 degrees all the time. It's only 40 degrees for a few hours around 12 o'clock, 1 o'clock. And then it goes down to 35, and then it goes down to 30. And at night, it might be 25. So how can I work out What is the damage when the temperature is changing all the time like this? And that's why we have this concept of mean kinetic temperature. What we try and do is measure the temperature at all the different times and integrate it and calculate it to the same as if the goods were kept at one temperature all the time. So the temperature is going up and down, up and down. I measure the temperature and the time, how long it is at each temperature, integrate it together, and I come up with this concept of mean kinetic temperature. Point around this, this is not a simple average. It's a complex integration to achieve this mean kinetic temperature. And mean kinetic temperature is specified in most of the good practice guidelines. Now, to calculate the mean kinetic temperature, I use something called the Arrhenius equation. Looks horrendous, doesn't it? Don't worry too much about it, because in fact, you don't need to know a lot about it other than it exists. In order to calculate the mean kinetic temperature, there's a module in Excel, and all you have to do is put the temperature and the time in Excel. So you might measure the temperature every hour. You would enter that data into an Excel sheet, and it will calculate the mean kinetic temperature for you. Or you can buy a cheap $50 data logger, and that will measure the temperature every 3 minutes and integrate it for you. And after 24 hours, it will give you the mean kinetic temperature to 3 decimal places, all calculated already for you. So this mean kinetic temperature is the temperature that I can think of as having stored the goods all the time. That's how much damage I can relate to for that temperature. So this mean kinetic temperature is not simple arithmetic, but it's not that difficult to calculate it with Excel or with a data logger. I could also use temperature sensors linked to a computer in the warehouse to do it. Basically, it's measure the high-low and put the results in a computer, and I get the answers. I don't have to be too hung up about this complex Arrhenius equation. I just have to know it exists. And WHO has conducted a review of which ones are good, and you'll find the links and you can find information on it. Which of these data loggers, and some are only $25, are actually any good and which work and which don't work. You can also use them in refrigerators as well as in the main warehouse. So why do I need to be doing this mean kinetic temperature? Because most pharmaceutical products can tolerate a brief exposure to elevated temperatures without being immediately destroyed. Just like my aspirin. It was at 40 degrees for 4 weeks. It wasn't damaged. Only when we went to 60 degrees did we get a damage. So if I know the MKT, I can then refer that back to the specific pharmaceutical guidelines in the pharmacopoeia for a particular product to see if it looks okay or not. That's one way of looking at it. Have I damaged the product with my temperature? I've done the MKT calculation. Now I can have a look and reference the product. And that applies to cold rooms as well. When I open the door, the cold room temperature will go up. Some items will move around that. And again, for many products, the pharmaceutical specification allow me what they call an excursion, a trip to a higher temperature, providing it's not more than 24 hours. So if I monitor the MKT, the mean kinetic temperature in my cold room, I can see if I'm within the range or not. Transport in a hot truck, my distribution might be possible if I'm monitoring the MKT, if I don't allow it to go above 40 degrees, and I can calculate back on that item. Depends on the specific item. And you'll all be familiar with the pharmaceutical classifications of warm, heat, freezer, and cold. They're given there for you again. All right. So most pharmaceutical products are stored below 25 degrees. As a very crude guide, raising the temperature by 10 degrees doubles the rate of deterioration. What does that mean? If I was to store at 35 degrees all the time, 24 hours, or if my mean kinetic temperature came out at 35 degrees, the shelf life would be reduced. If I had a 2-year shelf life, it's now a 1-year shelf life. That's the impact of a 10-degree rise. Not 10 degrees for half an hour. I'm talking about a mean kinetic temperature, 10 degrees, or permanent storage of 10 degrees higher. Above 40 degrees for more than 24 hours usually damages the product too much, and I can't use it. During transport, 50 degrees is possible inside containers, so I do have to look at monitoring containers and finding ways to reduce the temperature in transportation. Simple way of doing that is specifying if it's overseas shipments by sea, no deck cargo. When it's on the deck, it's in the full sun. It could get inside the metal shipping container, it could get to 50 degrees. If I don't allow deck cargo, it's inside the body of the ship. It's not likely to get to 50 degrees. So there are simple techniques we can use to help moderate the temperature. In the warehouse, what I have to do is a system called temperature mapping. Yeah, can we go to mute, please? Everyone on mute. Yeah. And to do that, recognize not all areas in the warehouse are the same temperature. Some are going to be hotter than others. So if I map the warehouse, a temperature map, and identify the hot areas and the cooler areas, those products which are temperature sensitive, like the ergotamine, I can put in the cooler areas. And those products which are not that sensitive, like the aspirin, I can put in the warmer areas. I hope that makes some kind of sense, because too often in the warehouse, we just take an item and put it on the shelf. We don't think about what the temperature in that area is. So part of good storage practice is to undertake temperature mapping of the warehouse, identify the hot and the cold spots. There's detailed instructions in the WHO guidance on how to undertake temperature mapping of storage areas. Main point is to do it, see where the highs and the lows are, and then think about the products I'm going to put in the cooler areas and in the warmer areas. Segregate by product temperature liability. So why am I doing this? To identify the best places to locate temperature sensors and temperature sensitive products. I can't just have one thermometer hanging on the wall in the warehouse and say that's the temperature. I have now to temperature map the warehouse. That's part of good storage practice. And once I've done that, and it's relatively cheap to do, sensors now are just like $20, $25. They're not expensive. Monitor the areas of the warehouse and look at where I can put the more temperature sensitive items. So even if I haven't got any funding, I can do temperature mapping. I can already start to improve my storage practice by getting items in the cooler areas and non-sensitive items in the warmer areas. Might seem very complex, but with modern technology, it's not a big deal. I just put the temperature sensors all around and map them in. Many are Wi-Fi operated. I can link them all back to a central computer and get the whole map of the warehouse built for me. There's lots of software to do it, to assist on that. And it's a simple step forward towards good storage practice. I can also do temperature mapping in cold rooms, in walk-in refrigerators, often called reefers. See where the cold and the hot spots are, and again, put the most sensitive items in the cooler area. Next to the door is usually a warm spot because I'm opening and closing the door of the cold room, so that's not a good place to store the really sensitive items. Better off inside. So vaccines in the cooler areas, some of the refrigerated diagnostics I can probably put closer to the door. Okay, I see we're just about on time. So, Q&A session again. Again, if you would like to put anything in the chat box, or if you'd like to raise your hand. Nothing so far. Okay. All right, then let me ask you, and please answer in the chat box. How many of you have undertaken temperature mapping of your warehouse? Just answer yes or no in the chat box. Just type that in, please. How many of you undertaken temperature mapping of your warehouse? Ooh, looks like we got a lot of no's coming in here. Okay. Never did. Okay. Oh, I got a yes, Vivian. Okay, I got a yes from you. Vivian, can you say a few words about what you did? Would you like to unmute and just say a few words about what you did for temperature mapping?
Yes.
Go ahead, please.
Good morning, sir. Actually, I was before 3 months back. So we put them in 2 different rooms, and I put them in 2 different locations, one right firing and the other close in the second store or the outer store and close to the door. And I realized that the temperatures, even when the entire room is sealed, like over the weekend, are not the same. So the inner room that had a much lower temperature than the outer room and then closest to the door. So from there, I could put those things that are temperature sensitive right in the inner room and those that are not so sensitive to the outer room.
Excellent, good. Recognition that it's not all one temperature. Yeah, a major point. Yep. Thank you. Okay. Then let me ask everyone, how many of you have got good storage practice certification? Has any of our stores got good storage practice certification? Maybe we've got somebody from the private sector who has it with us. More no's coming up. No. No, okay. Okay, we've had good storage practice for over 20 years now. Why is it that we're not getting it implemented? Why are we not getting good storage practice moving along? You got any ideas why we don't have GSP? Okay, then if we've got any other questions on any aspect of storage and distribution, please raise your hand or just type into the chat box. Any questions on this module on storage and distribution? We talked a lot about storage, not so much about distribution. So if you've got some questions on distribution, please enter them in the chat box and I'll try and answer them. Okay, Tawanda, do you want to? Okay, no, okay. If you want to just unmute and ask the question, that's okay. Just unmute yourself and ask the question.
Hello, sir.
Yeah, Daryl, please go ahead.
I'm trying to refer still to the Vivian, what Vivian have said earlier. And I don't think that is the temperature measurement. What you are trying to refer is that do we have any application that can dictate that this temperature on this angle is higher, more than the required wet medicine can take? And what she is saying, she's also saying about the heat within the angles. Maybe if the sunrise close to the door, there will be heat, and then to the other side like that. But the temperature measurement per se, it has to do with an application to dictate actually whether that temperature is more than the required of that medicine in that very situation. That's what I'm thinking.
Okay, there are really 2 points there.
Okay, sir.
One is temperature mapping. Where are the hot and cold places in the store? And that's what Vivian was describing. She mapped the store and found that close to the door of the cold room, it was warmer. The second point is this mean kinetic temperature. Is this temperature high enough to damage the product? And that requires mean kinetic temperature monitoring, which is a second step, really, of continuous data logging recording. These devices are now very cheap. You can do both at the same time. You can do temperature mapping and mean kinetic temperature at the same time on a modern device. But if all you have is a thermometer or a temperature monitor, then you can just do temperature mapping.
Okay.
2 points.
Okay.
Temperature mapping, where's the hot spots? And then is this hot enough to damage the product?
Okay, thank you.
Okay. Anyone else, please just unmute and ask a question. Don't be shy, we're all friends here. Okay, so we're coming up to just about 70 minutes. Priya, are we okay? Is we probably enough for today? Or...
Yeah, yes, sure, sir. I guess if there's no further questions from the candidates, we can just end up the session. I got one question. Can you please share the standard requirements for GSP such we can start implementing?
Yeah, the links are on the slide for GSP and GDP. You'll also find them throughout the module and in the reference material for the module. But I can probably try and do that now as well. Okay.
Okay. So also the final PPT and the recording of this session will be shared with you soon. And meanwhile, if there are no further questions, then please allow us to end up this session. So can we end up the session? I hope everything is completed from your end.
Yes, all done. Okay, since there's no further questions, but you can come to us anytime, email any questions that you have. Okay.
Okay then.
All right.
So,
bye to all.
Thank you again. Thank you, sir, for your support, for your time.
And happy Diwali to
session
all the
went very
team in India. Yeah.
Same to you. Happy Diwali to all.
Thank
Okay.
you, Priya. Bye.
Bye for now.